also like to thank our partners in this evening's presentation, the ONS Foundation. The foundation is a charitable organization specializing in research and education, so we thank them for their time. I also want to thank the rest of the panelists. I'd like you to focus on the fact that this is a team effort between doctors and the high school. And we thank you parents as well for coming, students, because it takes a full team to focus and care for someone who has suffered from a concussion. So with that, we would like to start by showing you a short video that our very own Greenwich High School students prepared with their enthusiastic response and interest in concussions.
Hi, I'm Avery Formato, and for this special episode of Cardinal News, we will be talking about a major health issue, not only for GHS athletes, but for the entire sports world as well. That is concussions. A concussion is a traumatic brain injury caused by a blow to the head, with symptoms like loss of balance, headaches, neurological deficits, and tracking issues with the eyes. Millions of athletes of all ages face the risks of having a concussion or getting reconcussed. For this episode, we will have Ian White sitting down with Mr. Peter Fowler, the GHS athletic trainer. We will also be introducing terminology and awareness to concussions. I will be sitting down with a GHS athlete who has also had a concussion. I hope you enjoy.
So here at GHS, what sports have you seen generally produce the most concussions and that you have to worry about athletes being the most safe during?
At Greenwich High, it can happen, concussion can happen in any sport. Predominantly, the highest rates of concussion that I see occur with football, soccer, cheerleading, hockey, and rugby. But I have to stress that it can happen in any sport. It doesn't take a hit. Sometimes it's quick rotation. It happens in gymnastics. We've had concussions where, student athletes have slipped and fallen getting off a bus on the way to a venue, or a motor vehicle accident. So concussions can happen almost anytime, anywhere. But certainly with the higher contact sports such as soccer, football, cheerleading, hockey, rugby, those are the predominant contact sports where I see the injury occurring.
All right, so on any given year, how many students come into your trainer's room with symptoms that could lead to a concussion?
On average, about 75 to 100 student athletes per year with concussion symptoms. Not all of them are diagnosed concussions, but they go through a screening process. Generally, I advise the parents to start with their pediatricians first and then move on to specialists if there's a protracted or prolonged recovery period. And I can recommend also referral to specialists like a neuropsychologist, which can help with re-entry into school, return to learning programs, and then in terms of helping myself when the student athlete is ready to return to play, I help with that as well. We do a return to play progression, which is a 4 to 5 day progression of graduated increased activity to make sure that the student athlete remains asymptomatic. And at that point, if the physician is happy with their progress, we can release them to full activity. Well, we're watching the games closely when I'm on the field, watching for contact, watching for hard hits, contact with the ground, and because of the media, the increased media awareness and the public's awareness of concussion, we see more kids helping to self-report, and that's been a positive thing that I've seen over the last few years, where you can't see everything, but another player will come to me and say, "Hey, take a look at number 42. He doesn't look right. I think he took a hard hit." So if I miss something, what I'm seeing is that other student athletes are stepping up and helping to identify, those that have possibly suffered a concussion.
I completely agree. I think when it comes to concussions, like communication among a team is definitely very valuable. So, what is the exact procedure you follow when you suspect an athlete has suffered from a concussion?
Immediate removal from play. So when in doubt, sit them out. That's sort of the mantra that we preach. But we do a sideline. As an athletic trainer, I do a sideline evaluation. We check balance, memory. There are questions we call Maddox questions. We test for amnesia. We look at the eyes. We look at the pupils to see if they're equal and reactive to light. Like I said, balance testing. There are some other sideline tests that we are that are in the works. There's a test called the King-Devick test, which is something we may put into play in the next year or two, taking a look at how fast someone can track numbers on a sheet of paper, and that can be indicative of a loss of function, because a lot of the symptoms or trouble that kids have with a concussion is that it's through their eyes. So reading tends to be one telltale sign. But we do a battery of tests on the sideline, and if sometimes you see the student athlete walking back to the huddle or off to the sideline, or be confused in the game and not really look themselves, and that's a telltale sign to pull them out. If they're not in the right place and doing the job that they're supposed to be doing on the field or court, then usually you can tell something's wrong.
So if an athlete that's suffering from a concussion cannot get to a doctor immediately, what temporary measures are there in place to lessen the discomfort or pain they feel at the moment?
Well, anyone suspected of a concussion, I advise to seek immediate or as soon as possible medical care. I, as a medical professional, can help gauge how important it is to either go to the hospital right away or to not go to the hospital. There are certain red flag symptoms that are present that warrant a closer look immediately versus or present sort of an emergent situation versus a non-emergent situation, where a general concussion can wait till the next day, as long as their symptoms are improving, to see their pediatrician or a specialist. But there are signs and symptoms like vomiting, loss of consciousness, difficulty with their balance, worsening of symptoms that would indicate, an emergent situation and a need to go to the hospital.
Great. Well, thank you so much for being with us, Mr. Falla. This has been Cardinal News. Thank you for watching.
Excellent panelists this evening. I'd like to start with Dr. Paul Sethi. He's an orthopedic surgeon with Orthopedic and Neurosurgery Specialist, or ONS, in Greenwich. He was an all-Ivy League athlete and graduated with honors from Cornell University. And he completed a sports medicine fellowship in Los Angeles. Students, he was an assistant team physician for Los Angeles Lakers basketball team, LA Kings hockey team, LA Dodgers, and the University of Southern California football team. He is currently on the faculty at the Yale University School of Medicine, and he teaches advanced techniques in sports medicine surgery. He is a team physician for Greenwich High School and Iona Prep, and we glad to have him here. Trista McDonald-Ryan is a pediatric neuropsychologist. She works at the Gaylord Hospital Center for Brain Health, and she specializes in diagnostics and treatment of traumatic brain injury, or TBI, in children and adolescents. She performed her residency at Atlanta VA Hospital, and she was working with veterans who suffered from TBI. Her postdoctorate fellowship, she specialized in pediatric neuropsychology. You can find out more about their bios on the flyer. Dr. Scott Simon is a neurosurgeon specializing in the treatment of spinal disorders, including operative and non-operative treatment of scoliosis. He regularly treats patients with concussions from sports injuries and other causes. He is one of just a few physicians nationwide trained in neurological surgery and orthopedic techniques to treat scoliosis in adolescents and adults, and has extensive experience in minimally invasive spine surgery. He conducted his fellowship training in spine surgery and scoliosis at the Shriners Hospital for Children in Philadelphia. We have a very tight panel this evening. We're going to move through quickly, and I'll introduce the rest of the panel right before we begin their section. And with that, I'd like to turn it over to Dr. Simon.
Hi, thank you so much for having me. Can I remove this?
You can, just pull it out from the top.
Okay. I feel like a lounge singer. So I'm quickly going to go over what concussions are. Here's our agenda, but we're going to move on forward so you're going to see it firsthand. Concussions obviously are in the forefront of the media because they're so common and they really have no, they're irrespective of any kind of socioeconomic class. They occur throughout every socioeconomic class in geography. And contact sports are certainly the main venues we see concussions. And they're not only men, they're women too. You can see this study from the NCAA sports that while football is the main venue where we see concussions, it's also many of the women's sports. And we see that concussions can happen sometimes more commonly in women, and often the symptoms last longer. Now, there's a myth that concussions only really happen in sports. So you can say, well, my son's not really a jock, he's more on the band and whatnot. But even just riding a bike, we see in those under age of 12, we see that that's the most common area where we see concussions, either bike or rollerblade or skateboarding accidents. So what is a concussion? I equate a concussion to pressing the reset button on the computer. And so the computer winks out. And then you have to wait till it boots back up. And that's what the brain is doing. It's a reversible traumatic brain injury. We no longer classify concussion as mild, moderate, or severe. We just say concussion is a mild traumatic brain injury, and it's reversible, meaning that there's no evidence to show that there's any long-lasting effects from a concussion that's structural. So the majority of the concussions spontaneous resolve after 3 weeks. Another myth is that concussions don't have to have a loss of consciousness. Only around 10% of concussions are associated with a loss of consciousness. So, oh, he never got knocked out, he didn't have a concussion. That's not the case. So why do we see so many more concussions? Partly, we're identifying them so much more. We're not saying that people who come off the street with just a little dizziness and unsteadiness have their bell rung. That's a concussion. And when you get an imaging test on these patients, they're often normal. So whether it's CT or MRI. So what's happening in the brain? I love this picture because it illustrates what's going on in the head. So what you have in the head is you have the skull, and inside the skull you have the brain. And the brain is not fixed to the skull, it moves independently. Just like when you hold an egg up to your ear and you shake it, you hear the yolk rattling around. That's what the brain does. So yes, a concussion can happen after a direct trauma to the brain, but it doesn't have to. It's the torsional and rotational acceleration and deaccelerations that happen within the skull on the brain that cause the concussion. And so this torsional acceleration and deacceleration is really the main driver of the concussion. So you can have a big helmet, but as long as that brain is rattling around the skull, it's still going to be susceptible to a concussion. Lateral hits or lateral rotational forces are more likely to result in a more severe concussion than front to back forces. And we see that concussions often can happen during practice, even with these lateral hits. What happens with concussions when someone gets a concussion? As I said, you can have a loss of consciousness, but the majority of concussions happen without a loss of consciousness. As that video stated initially, you can have poor coordination or motor instability, dizziness, lightheadedness, fatigue, visual changes, emotional lability. I mean, these are adolescents too. So imagine taking an adolescent and making them even more emotionally labile. That's pretty bad. And they can have severe and long-lasting effects from this. Delayed verbal and motor responses. And it's very difficult because we often talk about return to play, but we're also going to talk very heavily today about return to academics. These are kids in the prime of their high school years looking forward to placing into the college of their choice. So we have to be very mindful of getting them back on track for that. And typical symptoms: early headaches, dizziness, vertigo, lack of awareness of surroundings. Late symptoms: you can have persistent low-grade headaches, lightheadedness, poor attention, memory dysfunction, easy fatigability, irritability, photophobia, phonophobia. They just don't like being in a light or crowded room. And the science is moving very fast for concussions. And this is something that's so, so true. We're learning more and more about concussions every year. However, the media attention is moving much, much faster. So the spotlight on concussions is white hot, but our ability to really understand what to do and when to do it is sometimes lagging behind the attention. So that's sometimes a frustration for us and our parents and our patients. So we're going to talk about how these symptoms affect academics and reduce anxiety. So I'm going to leave it up to Dr. Ryan to discuss that as well.
We're going to take questions and answers at the end. If you have questions, inside your packet is a blue card. So write your questions down, you pass them up, and this way we'll be able to get through all the things that arise.
While you've got your pack, we're referring to your packet. Inside, if you all just don't mind opening it up, because there's a sheet in there I'm going to reference, and the sheet looks like this. It's a school recommendation form following concussions. Okay, so just have that handy, and I'll get to it in about 5 minutes or so. Before I go on, I just want to get a feel, we'd like to get a feel for who's in the room tonight. Who in here is a parent who has had a concussion in their own time?
How about ourselves?
Yourself, as an individual yourself, that you've had a concussion yourself. Okay. You've had a child that's had a concussion. Okay. Okay. Is little child, young child with a concussion? Middle school? High schooler? Okay. Who here is from the high school? Like representing, okay, is this anyone from the middle school PTA? Elementary school PTA? Okay, great, all right. Well, we are going to be talking about, for the next half of this presentation, about really how do we hone in on some of the myths that are out there, because the media is going so much faster than the science. The science is fast. The media is much faster right now. And what's in the media is often incorrect. So there's a lot of inappropriate myths, and these myths could be related to what we used to know about concussions. So everything Dr. Simon and I and Dr. Sethi are talking about is what we know about concussions right now in this time on March 9th? March 9th, 2016. We may know differently a year from now because the science is moving so fast. So I'm going to touch a little bit on some myths and then really hone in on the effects in academics. And then the goal is for you all to leave here feeling less anxious. If you feel empowered through education, your child's going to get the best outcome. Okay. One myth that's needs to be dispelled is that if you look at this question, which of the following estimates of recovery from injury are most accurate in teens? What do you think? Anybody say A?
That's what you said earlier.
B?
C. Come on, someone's got to commit. This is a test.
E. Right, all of the above. But concussions aren't the same for everyone. Right? So there's a myth that, oh, my child had a concussion and it took him 4 months to get better, so that will be what happens if your child has a concussion. Well, that's not true. No two concussions are the same. Every child responds differently. And there's reasons for that. Okay, so there's risk factors. We all enter with a risk factor. Risk factors from a neurological standpoint of migraines, history of concussions, our genetic makeup, neuropsychological risk factors that include your mood, if you have a mood disorder, if you have learning disability, attention deficit disorder, preemie, if the child is a preemie, and just even your temperament is what we're learning. And when we think about the high schoolers, this is important because we are in a county here of a lot of high perfectionistic, high achieving kids. Right? Anybody have one of those? I have one, and then the other I wish was more like that. But this can be a factor in recovery. The other factors include age. So kids are not mini adults. Kids can take longer to recover than adults. Gender, Dr. Simon already touched on this. Females can take longer and to have more symptoms, concuss more easily, and take longer than male counterpart in the same type of injuries from a sport. And then there's other medical factors, including visual convergence dysfunction, neck pain that could be associated from the injury, as well as the family system. And this one may surprise you all. And here's what we found out. So when we look at the research in severe traumatic brain injury, so we're talking about mild traumatic brain injury. In severe traumatic brain injury, we've known for years that the family system is a huge component to recovery. We're now just starting to look at what does it look like in mild traumatic brain injury. So there is a great study that came out last year that ran a correlation between parent anxiety around their child's academics and around their child's outcome for sports. I want my kid to play college basketball. This concussion is going to interfere with that. I want my kid to go to an Ivy League school. This concussion is going to interfere with that. So that anxiety that a parent comes to the table with at the time of a concussion is a huge factor in outcome. The negativity, I use a word when I give these talks a lot, awfulizing. I know it's not a word you'll find in the dictionary, but the more you as a parent awfulize, this is awful. You're supposed to take the SATs this weekend. This is horrible. This is horrendous. This is awful. The harder it's going to be for your kid to recover. So if there's one thing you leave from here tonight, it's that you do have some control in your child's outcome. You may not have been able to control that they had a concussion, but you can control how you respond to that concussion, okay? And then the family dynamics is critical. So family dynamics plays a huge role. If you have multiple kids, if you're a working parent, you're trying to multitask, taking your kids to multiple appointments, and that's extremely stressful. When your kid has a concussion, everything stops, and you've got to be at home with them, or you've got to take them to appointments. So that whole family system and the dynamics of the stress needs to be recognized, not only within yourself to say, oh wow, we are really overscheduled right now, we need to take a step back, but also by the people who are providing care for your child. To be able to say to them, you know what, we've just got too many appointments right now, can we just maybe take one appointment for this instead of 2 this week? To the teachers around you as well, to understand we're under stress. To get the optimal treatment for your child, it's an individualized treatment plan, right? So no 2 concussions are the same. So care needs to go down to the individual. What is that individual's risk factors? What is the individual's symptom? How severe are they, and what are those symptoms? They need to be educated. They need to be reassured. So there's another great study that gave kids an idea that their outcome was going to be horrible. Again, that awfulizing idea. It's going to take you a long time to get better. I'm really sorry about that, and there's nothing you can do. So, when she hears that message, what do you think is going to happen?
Shock.
She's going to get depressed. You think she's going to get better really fast? No. She's going to take a long, you've created an outcome, right? So reassurance is the best medicine in concussions. As well as good treatment includes a triage to vestibular therapy if needed, right? A triage to neurology, neurosurgery, a triage to neuropsychology, and to mental health. And that's all going back to a really good assessment in the beginning and understanding risk factors. So who's who in the management of concussions? There are a lot of people out there managing concussions right now. Who's who there's brain specialists by training, so that would include neurology, neurosurgery, neuropsychology. Then there's other subspecialties. There's other specialties with a subspecialization in traumatic brain injury. And within this group, there's going to be good and bad, right? So you could find someone on this side who might be a brain specialist, but they might not know as much about concussions as somebody over here. So what you need to make sure you're doing is really understand who your child is going to see, okay? And when you're taking referrals, there could be referrals, and Pete may speak to this because he's both an AT and a PT. PT, oh, can you go back one? You could get referrals in your child's treatment to physical therapy. You could get a referral to neurooptometry, to mental health providers, to an athletic trainer for a return to play, okay? So it's not just one-stop shopping in terms of I'm just going to the pediatrician. You may end up having to see multiple providers. But that's where you as a parent need to say, hold on, can you understand my family system and we're getting overwhelmed? How can you help me not be so overwhelmed, okay? Has anyone heard of Cocoon Therapy?
Yes.
Yes, okay. So there's this therapy that's been referred to as Cocoon Therapy where kids have been told, go sit in a dark room with no stimulation for days, weeks. I've seen kids who've been told to do this for months. And as a result, it leads to depression and longer recovery. Okay? So when you hear this, you need to cocoon your child. Absolutely, they need to have a reduction in stimulation. But they do not and should not ever be put alone and isolated in a dark room for hours, for days on end. The other is, well, just rest. There's nothing you can do, you can just rest. So Dr. Simon referenced that rest and through rest, the brain will heal spontaneously, right? But that doesn't mean there aren't some things you can do to help your outcome. One is you need to understand when you have a concussion, you get tired, and your sleep cycle can get messed up. And as a result, what we always suggest is for the first couple days, sleep. But after that, you really need to be making sure your naps are short so that you don't have an interference in your sleep cycle. Another, we used to say, no returning to any exercise until you're symptom-free. Well, we know now from this great study that was done in Buffalo that depending upon if it's an athlete who's in really great condition, we want to get them back to doing light exercise within that week, first week. Certainly within 3 weeks of an injury. So in order for the brain to get some stimulation from an oxygen standpoint, you need to get the cardiovascular system moving. And so exercise is really important, and we are learning more and more about that. We used to say, no school, no exercise until you're 100% better, right? Well, now we're pulling back from that and saying, no, exercise really is very important, has to be supervised, and it's got to be done at a time when your doctor says it's time to do it. And then soft tissue work to the neck is a critical piece, and Dr. Simon can speak more to that as well as Pete can. And nutrition and fluid intake. 64 ounces a day. Got to have your fluid intake for concussions. So I am a pediatric neuropsychologist. And what neuropsychology is, have any of you heard of neuropsychology? Some people think of it in terms of my child has a learning disability or ADHD, so I've gone to a neuropsychologist. That's a little bit different from neuropsychology in the neurological field and brain injury field. It's the neuroscience of behavior, emotion, and cognition in the developing brain. And it gives you the functional picture of the CT scan or of an MRI as it relates to how a child is functioning along these lines in home and in school. So the role of neuropsychology, if you should get a referral, and tonight we're going to be honing in on what a neuropsychologist does, but more importantly, what happens in the academic world, and the two tie together. When a child has a concussion, a neuropsychologist's job is to tease apart what's going on. So Dr. Simon referred to, well, after a head injury, a child may have more labile mood, right? More irritability. You think, well, isn't that all teenagers, right? So one of the roles is to look at, well, what's typical behavior? Or what's pre-existing? What are the pre-existing risk factors? Does the child have ADHD or a learning disability? What are the neurological considerations in terms of symptoms? And then what are the mental health risk factors? So it's a targeted evaluation of anywhere from 1 to 3 hours. It's not a full, like you hear of like 6, 8-hour batteries. It's targeted. And it's more specific and sensitive than computerized tests. So it's not impact testing. It's not CogMed, it's not Axon, any of those other things you see out there in the market. This is very different from that. And it fine-tunes an academic plan. So I want to go back to what are those symptom categories. So Dr. Simon reviewed that the categories revolve around physical symptoms, cognitive symptoms, emotional, and then sleep. When we think about academics and returning to academics, it's critical to think flexibly. In order to get the best outcome, you might need to do things a little bit differently. You also need to think in terms of the brain's capacity and efficiency. So if you start your day off in the morning with a full bottle of water, right? That's your capacity. How much you have to start the day. So think of this as the neuronal energy available to you. Well, with each thing you do during the day, you're taking some capacity out, right? You're using some of your energy. When you think of concussion, if you only have so much energy, you want to think about, where do I want to put that energy? How do I want to use that energy? As a parent, you want to think about, okay, for example, my child takes the bus to school. Is that a good use of their energy? Or would it be better if I could maybe drive them to school? Let me think about their school day. Is it a good use of their energy to be in art class as opposed to having a full cup, a full bottle when they're in math, right? So that makes sense? So you want to think flexibly, and you want to think, where do you want to use your energy? And every time you pour from here, you want to rest so that you replenish. You pour out, you rest, and you replenish. And it goes like that. It's like a seesaw, back and forth. And so it's this idea of capacity and efficiency, and how are you going to prioritize what your child does, and how is the teacher going to prioritize what the child does in the school system. And this whole idea is from a graduated response in returning to academics. So at the acute phase, which is really within those first few days, basically there's no school, no academic demands. And you're going to start off with these little mini exercises. So you go through a 10 or 15 minute exercise where I'm going to think about doing some math, or I'm going to do some reading for 10 minutes and see what happens with my symptoms. Does it make my headaches worse? Does it make me feel more tired? If it makes my symptoms go up, I know that 10 or 15 minutes is really my max and I just need to back off. If I'm okay after 10 or 15 minutes, I take a break. I go back to it again and try to see if I can extend my time even further. Okay? So you're going to start with these gradual increases in your thinking. Time on task and intensity. And then you graduate to going to school for partial days with partial demands. And that's where I'm going to refer to this in a minute here. And then you're going to increase the length of day and increase the intensity. So it's all based on the length of the cognitive capacity in terms of how you want to stress that system, as well as the intensity. You're going from no homework to homework and no test, all the way up to full demands. Does that make sense? Let's go through the symptoms and what that looks like in the classroom. And that's where, this is a form that when you go see a specialist, whether it's your pediatrician or you go see a concussion specialist of some sort, you should leave their office with something like this. Okay? There's a reference list in your folder here. So if you look in here, there is a sheet that gives you get the facts. Okay? You can go on any of these websites here, any of these links, and get more information. In addition, you can go on, the bottom link talks about, this is from the American Academy of Pediatrics. So it's one sample. But this is one sample of, there can be a lot of different forms, but in general, what these forms do is address length of school day, any accommodations that are needed, homework, so on and so forth. Okay, they're very specific. It's what these guys love to see. So when we move over to them, they'll say, please get one of these forms. Let's talk about the visual system. So what happens with the visual system after a concussion is that a child may have trouble converging their eyes in order to be able to read and to smooth pursuit. Okay? So for example, Dr. Simon might take you through an evaluation after a concussion and say, follow my pen. You can't see, but her eyes come together. They converge. Okay? Sometimes after the concussion, they won't converge. And that gets in the way of reading. He may also say, I want you to follow my pen this way and this way, right? And you can't see, but her eyes move nicely back and forth this way. And that can get in the way with reading, and we're going to give examples of what you can do in terms of auditory, reading, reducing demands. Same thing with fatigue and headaches. There is the how that interferes in the classroom and what you can do about it. A focused and sustained attention. Focused attention is your ability just to attend. So these are 3 digits. 7, 9, 4. Repeat them back to me.
7, 9, 4.
Right, that's basic attention. Your sustained attention is your ability to sit here for the last 20 minutes. And what that does is from a concussion that will get in the way of these factors at school. And these are things on your sheet that can be recommended for it. Working memory is mental manipulation. So instead of saying 7, 9, 4, I want you to say it backwards now. So instead of forward, 7, 9, 4, say it backwards. Yeah, okay? That's working memory. Working memory is really needed for math, for the sciences, for problem solving, for foreign language, following a discussion, and often we'll say, maybe instead of going to math, don't use all of your energy all in class. Go meet with the teacher for 20 minutes, one-to-one during their free, or before school or after school to get the content. Processing speed is your quickness. It's needed for following in discussion, keeping up with your notes, reading comprehension, and these are example recommendations you'll see on a form like this for it. And then new learning and memory. That's the ability to learn something and be able to retrieve it. That is impacted. Often, kids don't have a problem with memory, they have a problem with attention. So the cornerstone of concussions and cognition is attention and working memory and processing speed. If you can't attend, you're not going to remember. So often in an assessment, I'll find out your memory is actually fine, and I'll tell a child that, they'll be so happy. And I'll explain, no, it's actually that you're not able to pay attention, and so you're missing the information. You just never heard it, so that's why you don't remember it. And then executive functioning, which is planning and organization. So here we have the Greenwich High School response team, and I'm going to let Mary Stewart introduce the rest of the panel. And each school has been charged with the challenge to create these response teams. And you're very fortunate here tonight that you've got these individuals that can answer questions as it relates to their particular specialty and how they can be helpful when your child has a concussion.
Thank you very much. Appreciate that. One of the things that you missed in the video was a key statistic, and that is that on average, there are about 100 Greenwich High School students that suffer a concussion. It's a lot of attention that this team pays to our students, and each one is individualized.
This is per year?
Per year. There have been 41 so far this year. So I want to thank our team for their intense work, their volunteerism tonight, and their ongoing communication and work with each other, with the doctors, and with you, the families. And I encourage you to continue to work with them. So with that, I'd like to just refresh your memory. Dr. Paul Sethi is an orthopedic surgeon at ONS. He has a medical degree from Mount Sinai School of Medicine. He completed his internship and residency at Yale University. And again, he's a team physician for Greenwich High School. We also have on our Greenwich High School team here this evening, Peter Falla. He's a member of the ONS sports medicine team since 1994, and he assists in patient care. At Greenwich High School, he's the athletic trainer. He provides medical coverage at sporting events, and he's the concussion management coordinator and impact testing supervisor. He's also a member of the National Athletic Trainers Association, a member of the Connecticut Athletic Trainers Association, and he's certified in CPR for the professional rescuer. Marianne O'Connell has been at Greenwich High School for 16 years. She's one of 3 registered nurses in the health office that takes care of both students and staff in all 5 houses. She's responsible, and prior to Greenwich High School, she was in critical care nursing for 16 years. And Judy is our coordinator of Greenwich services for the District of Greenwich. She works closely with all the school counselors in grades 6 through 12. She's also the district Section 504 coordinator, and she's been with Greenwich Public Schools for 16 years and in education for 31 years. So with that, I turn it over to Dr. Paul Sethi and thank him for monitoring this.
Thank you. So first of all, thank you to the PTA for sponsoring this and Mary Stewart for helping to put this all together. Thank you, Dr. Winters, for letting us have your school for a little while. I'm always nervous when the headmaster comes to visit me. I think that in the next 10 to 15 minutes, and that's all we're going to ask you to stay for, so we're going to really sort of wrap it up and keep it concise, but when someone comes in to see me for a problem, they've blown out their shoulder, they've torn their ACL, the first thing that needs to happen is after you've got the diagnosis and you get over the, oh my gosh, what am I going to do? Well, what are my steps? How do I visualize this? Who is my team to help me get through this problem? And in the exact same way that a torn ligament or a broken bone is a medical diagnosis and a medical problem, a concussion is the same problem. And knowing your steps and knowing your resources, knowing who to call and who to identify, I think can really reduce, like Dr. Ryan said, reduce the anxiety of the student, reduce the anxiety of the family. And everyone says to me, well, how can I get better faster? I want to be better faster. Well, actually, this is how you get better faster. You become empowered with understanding it. You alleviate the anxiety, and you know who's on your team to help shepherd you through this event. So, if you're going to take any one piece of paper, in my perspective, it's this agenda with the names of Pete, Marianne, and Judith on there, because that's who you need to know, and that's who you need to call. And what I've asked them to do is each of them are going to introduce themselves in their best humble pie way, but more than that, they're going to tell you, what do they do? What are they able to do for you, and how can they help assist you and your student get through this event? So let's start off with Pete, who I stood on sidelines on rainy and snowy and hopefully 70-degree days with Pete. How do you get involved in a concussion?
Well, I'm there from the start, and I'm there for the end, in between the academic team and the people within the school. Really facilitate the learning portion and return to learn. But as an athletic trainer, identifying, I'm there on the sidelines, I'm there at the time of injury, identifying the concussion. It's not only myself. We're fortunate in Fairfield County to have athletic trainers at most, if not all, of our high schools and in this area. But the fact is, nationally, about 40% of schools in this country do not have an athletic trainer on staff or even servicing their student athletes. So we have a long way to go. But in the state of Connecticut, our coaches are well trained, a very thorough training regimen of classes that they take, a big part of which is concussion head injury training. Having an athletic trainer like myself on the sideline at the time of injury is important. And the ball really starts to roll with me. So at the time of injury, we remove from play. I mean, every state now has laws on the books removal from play if there is a concussion or a suspected concussion until it's either ruled out for sure. If you do, confirm that there is a concussive event, they are done for the day until they're cleared by a medical professional.
So let's just stop for a second. What are the no-brainers? How do you decide? Is there some sort of magical orb that you carry to say, oh, this is a concussion? How do you decide whether it's on the field or whether it's on the playing field or when you're skiing at Stratton? How do you figure out that someone's concussed? What are your no-brainers?
Well, it's like orthopedic evaluations. You're putting things together. Obviously, there's some hit or fall or some offending activity that could have resulted in a concussion. You see an alteration in function, and that you go through a sideline evaluation, not a clinical evaluation, a sideline evaluation to assess the injury. And if there's any doubt there, complaints of headache, dizziness, you observe the student athlete in their activities. In the video, it wasn't mentioned. We were unable to play it. But sometimes it's just the way they walk back to the huddle. Sometimes it's another player coming to help report the injury, which is happening more and more because of the education with our children. It's a coach maybe reaching out. I'm one set of eyes, sometimes with 20, 30, 40 kids participating. It depends on the sport. But identifying the injury, taking them removal from play, performing an adequate sideline evaluation, which we're not going to get too in detail with, but balance exercises, looking at the eyes, the way they're tracking, testing, memory. There's a program that I use on my phone called SCAT3, which is I have an abbreviated version of it, so we can get through it pretty quickly. There's a more standard version that you can do in a more clinical setting.
A little bit of drama sometimes, when they hit their head, there's more emotion than you would expect. And whether, again, I want to try and limit it to, it's not just sports, right? It's everybody, right? So these are the things I want everyone to go home with. Pete,
right.
One last point for you, and what do you do for, what else?
Well, the important part then is once you determine a concussion happened, the acute care process begins. And for me, that's contacting the parents immediately, parents or guardian, providing them with an acute care handout, either electronically or physically, which I carry with me all the time. I go over the acute care guidelines, not to use blood thinning medications, and we give them a symptom checklist of red flag symptoms that would precipitate an emergent situation where you would want to go to the hospital right away. And that would be loss of consciousness, vomiting, persistent worsening symptoms, balance issues, slurred speech, really red flag issues that might indicate that there's something worse than a concussion going on. And that's my job to make that call, whether I suggest emergent care versus maybe watching overnight and following up with a medical professional the next day. At that point, send them on their way, well armed with information, and then it's beginning the communication process with the school team, documenting the injury, filing a report, and emailing the nursing staff, making them aware of the injury in a very timely fashion.
That's a perfect lateral, actually. So now we've identified when you need to go to the emergency room. I think Pete's really nailed them all on the when do you need as a parent to take your child to the emergency room. It's not immediately, it's not every concussion. And we'll address when do you need to get a CAT scan and an MRI in a few minutes. But now, so it's the next morning, right? You think you have a concussion, or you've been to the doctor, you've seen Dr. Simon or Dr. Ryan, and you got the stamp. This is it. This is a concussion. Marianne, what do you do, and how do we contact you, or do we need to tell you? We've already told the neurosurgeon, right?
I'm Marianne. I'm one of the nurses in the health office, and I hope how we handle concussions is like this, in a quick way. We hope you talk to us. If you've already gone and you have your documentation, you have your diagnosis, your doctor's probably told you some restrictions, some academic recommendations, we can be your point person. So if you bring us your paperwork, you or your student, your son or daughter, we're going to notify the guidance counselor. We're going to make copies of all those papers. We're going to notify them first. They can communicate with the teachers. We're going to notify your gym teacher. So your student is not going to have to participate in gym, and they're going to be medically excused. So more importantly, they don't have to make the classes up. We're also, if they're a student athlete, we're going to notify their coach, because the coach might not know that a concussion was diagnosed. And we're going to notify Pete, because he can be involved once they start their recovery in the return to play protocol.
And that point is sometimes I'm not directly there when they happen. Sometimes it's at an away game. Sometimes it's not a sporting event. We've had a kid get hurt on a bus on vacation. We've had skiing accidents over vacation. for an athlete. And then, if I'm not there to initiate the process, the communication also works both ways.
So we're also there, we're gonna hear from you, but you might also hear from us. If your student bumps their head during the day, we're the first responders, so we're going to assess them, we're gonna take care of them. Obviously, we're gonna send them to the hospital if there are more serious symptoms, as Pete mentioned, seizure, disorientation, loss of consciousness. But sometimes we hear about the accidents that happened over the weekend, and they're athletes, they got a little headache, they feel a little sick, and you might not even know. So we're gonna call you, and we're going to talk about signs and symptoms of concussion. We're going to tell you what your child's presenting with after we assess them, and then we're going to recommend that you follow up with your doctor. If they're a student athlete at our school, we can also call Pete and their coach and just say, you know what, don't let them play until we find out what's going on, so we know they're off the field, which is better for us. And the last thing we do is we take care of them when they have their concussion, and they know they can come to us for medication. We can give over-the-counter medications. They can rest. They can get a nice, quiet, dark place if the light is bothering them. They can just take a break from a very chaotic environment. So we're there for them.
Marianne, can you just review again how many concussions, because you monitor what we have in the school right now. How many you have right now, and what's the status of them?
We have about 42 right now in the school. 22 have returned to play and returned to academics and are considered fully recovered. A lot of the kids are in a good place. We've had a lot of kids who've said to me, oh, I'm fully back to sports, I'm feeling great, but there has been a bit of a problem if they're not in gym class or they're not in sports and they don't need any accommodations. Sometimes they forget to come back and tell us, hey, I'm doing great, I feel fine. So it's nice to get the closure, which we're working on by just talking to them and contacting parents.
And last but not least at all, Judy, you're the final link on our team. Can you just let everyone know what it is that you do and how you interface with the student?
I created this green sheet, academic concussion management, with some of the points that I want to make here this evening. At the secondary level, in order to make sure the information gets out quickly, I definitely recommend contacting the school counselor and the nurse. You can do it in a quick email or a quick phone call. The counselors and the nursing staff, both at the middle school and the high school level, are very good at communicating with each other. Even if we're not 100% sure whether the other person knows, we always make sure to communicate to each of us so that we're all on the same page. Because each student is different and each injury is different, we do rely on timely medical information. And I remember, maybe 2 or 3 years ago when we first started getting these wonderful sheets with, very detailed recommendations, we were all very grateful that the, medical professionals were sending us such, very, key and clear information to follow. We rely on students to tell us how they're feeling and whether they're ready to do something. Many students will push themselves. They are very concerned about doing well academically. But the more we can encourage students to speak up and let us know what they're struggling with, the more we can adapt and be flexible to help them in any given day. Perhaps there's a couple of days where they're feeling really good, and then the third day they're not feeling good. We want to be able to help respond to their needs on any given day within the context of their recovery. The students, the counselors have a good deal of experience helping teachers know what types of accommodations or adjustments need to be made for students with concussions. And there are, I listed some that are typical or that are common, but that doesn't mean we can't be creative and problem solve with the student about their particular subject or the assessments that might be needed in a given time period to help them adapt to what's required in the classroom and modify what's expected so that they can take the time to recover before having the academic demands put on them. Last point I would just like to make, as the Section 504 coordinator for the district, both the Office of Civil Rights and Congress has indicated that typically a Section 504 plan is not appropriate for a concussion because they would say that anything under 6 months is not something that they would offer legal protection as a disability. However, academic adjustments will be made, immediately for students as soon soon as we hear about that they have had a head injury or a concussion. And we would certainly, if there's going to be a protracted recovery, have a Section 504 evaluation to see if there's going to be any ongoing disabilities that need more permanent accommodations.
So here's your team, right? So now you know the same way you sprain an ankle and you say, how do I get better? Well, I'm going to use rest, ice, compression, elevation exercises. How do I get better from a concussion in a faster, more thoughtful way? Well, here's your team. You've got a medical professional who's trained in neuroscience. You've got a neuropsychologist. You've got an athletic trainer if you're on the field. You've got your nurse, and you've got your guidance. And these are all the people you need in your arsenal so that you can coordinate the most effective recovery for your child, your student, and our patients. I've got a couple of prepared questions, and I think in the last couple of minutes, and I don't want to keep anyone from getting home and getting everything squared away. I'm just going to review a couple of major points. You know, Scott, first to you. It's Dr. Simon, sorry. It makes me call him that, actually. Does everyone who has a concussion need a CAT scan and/or MRI? Because, you know, when you hurt your knee, you do.
No. So if you get a CAT scan or you get an MRI, you're not looking for concussions. You're looking for something more serious.
What?
You're looking for a traumatic brain injury that may need admission to the hospital, observation, or even operative intervention. And that's not a concussion. Remember, I said a concussion is a reversible traumatic brain injury. And some of the best people to monitor a concussion is the parents. Now, when you know your children, you know how they feel, how they act, so monitor them, I think, is just as important. If there is any concern that it is more severe, then I think a trip to the ER is completely warranted. But again, you're not looking for a concussion. You diagnose a concussion with a blood test or an imaging study.
Perfect. Let's go to Dr. Ryan. How do I know when we're supposed to come see you? Mr. Paulson calls me up and says, listen, I think I have a concussion. I need to see Dr. Ryan today. At what point in the episode do they need to see you? Or can we just say, look, 80% of concussions in this age category are going to resolve in an approximately or under 2-week window? When do we need, or what point do you need to intervene?
So if a child is not resolving, the symptoms are not getting better in that window of 2 to 3 weeks, you certainly want to get a referral to a neuropsychologist. And make sure it's a neuropsychologist, not a psychologist who uses neuropsychological tests. There's a big difference. The other is if a child has had multiple concussions, we know then in that first step, remember you're individualizing treatment, right off the bat, that clinician says multiple concussions, or this is a kid with ADHD or LD or mental health, we want to pull in a neuropsychologist sooner than 3 weeks. We don't want to wait 3 weeks for things to spiral out. So it really depends upon the risk factors going into it. Know your child. What Dr. Simon said is the most important thing as parents you do is know your kid. And if you are worried and know their history, you want to pull in neuropsychology sooner rather than later. Because when we're pulled in too late, then things spiral out.
Perfect. Pete, you know, I've got this new iPhone app, and it actually connects to a mouth guard that has an accelerometer in it. And the accelerometer, while I'm on the field, can tell me how fast my son is running. And not only, then he can also tell me how hard the impact is. And do we have, by the way, this is true. This exists.
Science exists, yes.
And do we need this in every helmet and mouth guard, or are we missing the boat?
Right now, I would say no, because the science hasn't really isn't there to quantify how much force is enough force to be concerned about. The science is still evolving. There's companies out there that are really selling this stuff. It's not easy to monitor, especially for one athletic trainer. What kids do you give it for? You know, I mean, I had a company approach me and wanted to give me 14 units to try for a couple weeks. Well, if I have 800 to 1,000 kids to monitor and help here at the high school by myself, and most athletic trainers, you might have 1 or 2 in a school. So if my phone is going off every couple minutes, I'm really not going to be very effective at what I do. But really the base of it all is that the science is not there to let us know, hey, all these hits added up to 90 newtons of force, or one hit at 30 newtons of force is going to cause a concussive event. We don't know that yet, and the science isn't complete. It's not there. I think once it's established, we may see that down the road.
Perfect. Last question from me, and then we'll go to the audience. Marianne and Judy, I don't know if I wanted to tell you that my daughter had a concussion because I don't want it to be on her record, and I don't want a stigma because, you know, look, it's competitive, and I don't want anyone to think, I mean, is that all right?
No, I really think we need to know, and the sooner the teachers know, the better, because on the fly, they can help adapt in the classroom. So, you know, we want to be able to help the
And
students.
it's protected medical information, right?
Mhm.
Okay, great. I think we'll take a couple questions, and please stand up and just do me a favor, say it really loud. Your question.
Sure. I just happened to talk to my own physician this morning about CTE. What is it? What do we as parents need to know about that, you know, for the future for our kids?
CTE is chronic traumatic encephalopathy, and it's a term that's really been batted around quite a bit because of the concern over repetitive hits throughout a sports career that can lead to early dementia, Parkinson's disease. Junior Seau has unfortunately become the spokesperson post-mortem of CTE. He actually committed suicide in a way that preserved his brain and wrote a note saying that he wanted his brain studied because he suffered from a lot of these problems as well as severe depression. And so you see changes that are similar to Alzheimer's but also very histologically different in CTE. People have been doing sports for a long, long time without these things developing. And again, our knowledge of chronic traumatic encephalopathy is really evolving. It's a very rare event. I think more attention is being paid to it than is actually occurring. And there is some potential genetic factors that may be at play that lead to someone being more susceptible to development of CTE.
We don't believe, you know, in looking at our exact population, we don't believe that it's a single or even a second concussive event that's going to lead to this. This is someone who's been in a repetitive combative situation. So it is something to know about. If you open up any issue of Sports Illustrated, you're gonna read about it. But I don't know that it's exactly what we're worried about for our kids right now.
My daughter had a concussion last year at this time from a snowboarding accident. She just fell off a horse last couple weeks ago, and she's tall. She fell off a high horse. The helmet cracked. So what my question is, how much to invest in a helmet? How much help can a helmet be? I've asked different panels. Like last night there was a panel of doctors at Greenwich Library talking about concussions also, and I asked them. So I'm curious what you have to say about that. Is it worth paying $500 or could a $100 helmet be fine if it's certified?
So I'll touch on that one. I'll touch on that one. You know, I think first of all, helmets don't prevent concussions. Okay, helmets prevent life-threatening brain injuries. Would you agree with that?
Right. I think that I'm sorry to interrupt, but just to talk about Natasha Richardson, because that's something that comes up quite a bit. So this is someone who fell down, had a head injury, and was fine, and then was not.
Right.
And that was because she wasn't wearing a helmet and had a very different type of injury than a concussion. She had a skull fracture that led to what's called an epidural hematoma that led to her unfortunate death. That's not a concussion. So I think helmets are very important. Helmets do not prevent concussions.
So you should have a well-fitted helmet. I don't think you should buy the most expensive. There are a lot of claims, and they're really still being sussed out about whether one helmet is more effective or less effective. But a well-fitting helmet, I think whether you're skiing, riding a bicycle, I think helmets are critical and important as life-saving maneuvers, but not as anti-concussive devices. Cliff, and then I'll come to the side.
Yeah, so I may have missed this in the beginning, sorry, but in the pediatrician office, they offer brain scans in the beginning, so they say they can read the child's brain, and then if something were to happen, they can maybe see the differences. Somebody speak to that, or has somebody spoke to that? That worthwhile?
Oh, you're probably talking about impact testing.
I could handle that one.
The pediatrician office in the fall before they take on.
Right. So impact neurocognitive testing is a tool that is something that neuropsychologists use, and it's basically a small version, a compact version that's used by athletic trainers and other medical professionals, not neuropsychologists. Some do, but it's really a mix of different tests that are used, and it's put into a computerized version. Here as an athletic trainer, we offer the test to student athletes in contact sports or that have a high incidence of of concussion, and their freshman and junior year, athletes are asked to take the test if they like. We have probably almost complete compliance with testing them in their freshman and junior years. And what it enables me to do is we baseline test them when, preseason, when they're healthy. If they suffer a concussion, in the return to play progression, I can utilize that tool. If they're not seeing a specialist, that I can use that tool as an athletic trainer as extra peace of mind. It's not totally perfect in any way. As a matter of fact, it doesn't work well with kids with emotional issues, LD, ADD, other issues. But in the vast majority of kids, I've seen it work well. As I'm trained as one of 5 impact consultants in Connecticut as an athletic trainer, I'm using the tool and have done some coursework with UPMC, which is at the University of Pittsburgh, the people that have developed the test. It's sort of a gold standard for athletic trainers and some medical professionals to use. So we take that baseline test, and when an injury occurs, we can retest them post-injury. They recommend retesting a couple days later, and then down the road serial testing. I tend to use it mostly for return to play decisions. Once a local physician has cleared that kid to come back and play sports, I will use it as an extra tool. And hopefully what we see is the numbers sort of normalize. And basically what it is a test of colors, numbers, shapes, words, very similar to what Trish uses in the office, but in much more detail. Her tests are much more detailed. And she has many more in her arsenal. But it's a quick computer version, 20 minutes, that measures your immediate recall, delayed recall, your processing speed, and gives me, and it self-corrects, and it shows me how it compares to your baseline numbers. If they're off, it'll highlight them for me. And if they're off, maybe I'm going to make that decision at that point to refer to a specialist.
So Cliff, just to touch on it one more time, because there's more questions here, it's very nebulous about how well that data is going to work in the 9 to 12 or 13-year-old population. Under 15, right? So it's very nebulous at all. And for that matter, the over 15 is still nebulous. So I don't know that I'm quick to go and sort of screen everybody the same way you'd want to screen them for a strep test or anything like that. There were some questions on the left.
Yeah, I saw that at a few, like towards the end of middle school, that were relatively close together. At the same time, his grades and he went from being a very good student to really struggling. He's been since diagnosed with ADD, but is there any correlation to having concussions and it leading to that?
There's definite susceptibility risk factors that we identified. I think that some ADD, maybe one of them. Actually, I actually heard from someone recently that motion sickness is a susceptibility factor for a more prolonged concussion. So yes, there are definite risk factors that.
Can it be a cause of ADD, or is they're just too?
There's a couple of things. So what's interesting is the majority of concussions are happening in the adolescent population, right? Kids who come from high-functioning families or kids who are smart might be able to get through the system up until 9th grade. They hit 9th grade, and all of a sudden, we're seeing a lot more kids who are diagnosed with ADHD after a concussion. So there's one thing in terms of time proximity. Did they really have some features even before, but the workload reached the point because they were out of school and they had some weakness that it became much more obvious. So that's one issue on why we see ADHD diagnosed after concussions. The other is, there are multiple factors that a kid can have some prolonged attention problems after multiple concussions. So I can't speak directly about your child, but there is some, we don't call it ADHD, we call it attention in the context of a history of head injury, right? But more often I see a family that'll say, my child now has ADHD because they had a concussion or 2 concussions before. And I'll find out, really going through their history, they had some features, they had some weaknesses, but they were smart in other ways, and they were always able to get by. But then they hit high school, and the demands of high school were so much more significant. And not only that, but they missed a month of school in math, and so they were behind in math, and they couldn't pay attention in class because they didn't understand the material when they went back, and then their attention weakness becomes much more exacerbated in that context. So it's often something I will give a temporary or preliminary kind of diagnosis to, and then monitor.
And then a follow-up to that would be, if you mentioned spiraling out of control, I think was one of the, or spiral. What does that look like? And then, you know, if it's been years since it's happened, how do they, what do you do to help them get back on track if you think there might still be an issue from it?
You know, do you want to get into specifics of it? Just,
I'd be happy to talk to you after.
Okay, sure.
Yeah.
well, maybe that'd be better,
Okay, sure.
more thoughtful. You had a question?
Yes, can you talk at all about concussion prevention? I don't think you touched on that at all, unless I missed something.
Go.
That's a good, do you want to take that, Trish, or?
Well,
So concussion prevention, I think, is a very asked question because people talk about mouth guards and helmets, which we just basically said are not helpful. What is helpful is, number one, identifying concussion after it happens, but preventing a concussion is changing the rules of the game, making sure that in football people tackle correctly, don't lead with their head. We want to make sure that they don't put themselves in situations that will lead to concussion. So it's much more difficult to talk about preventing concussions or making sure concussion never happens with these children than it is about identifying the concussion.
and I think as parents, you are empowered. You might feel intimidated, but you certainly are within your right to get to know your coaches. Don't be afraid to know what their plan is, what their education is, and do they follow the right kind of drills, right? Are they following the USA Football recommendations for how you teach tackling? Are they following the USA Soccer on heading, right? So know your coaches and talk to your kids. Talk to your kids' friends.
I think more and more what is having also an impact in lowering the incidence of concussion is also decreasing the amount of contact during practice. So preseason practice contact has been curtailed. Heading has been curtailed in soccer. You know, there was a recent article in the New York Times talking about the Ivy League and how they have really gotten rid of contact.
And Dartmouth started 5 years ago and eliminated contact during practices, and went on to win the Ivy League championship. So the Ivy League is now, it's not a rule, it's before the commission to go more towards an NFL style of no contact practices. So that might be exposures. The number of times you cross the street is going to be directly related to your chances of getting hit by a car. Limiting your exposures when conceivably reasonable may be another idea.
I would just add to your list just in the future, like you can educate your kid. I'm a hockey player.
Yeah.
So head up, you know, that kind of stuff. And so to educate your kid, empower your kid to be aware.
Oh, yeah.
And to, yeah.
That's a great point.
And we're seeing changes even on the state level. 2 years ago, for example, football in the state has time limitations for total contact, which is new. 2 years ago, you know, to start the season, you're allowed X amount per week, and every couple weeks that amount drops through the season. They've even put in a bye week where a team has to take a week off.
All right, we'll take one last question because everyone has families and I don't want to keep you away from them, please.
Thank you. Well, first off, it's Brain Injury Awareness Month. I don't know if you all realize that, but that's why there's such great panels and events going on around the entire country. So on behalf of the national and local BIA chapters, I want to thank you all for your excellent efforts in adopting such wonderful mechanisms and standards to help protect the students in our town. I mean, from my heart. I suffered a head-on against the vehicle. And I was just wondering, you know, because this is concussion focused, you seem somewhat soft tissue centric in your analysis and discussion, whereas often a more serious injury can involve spinal, neurological, as well as you know, brain damage. So you see, the discussion seemed to shy away from that a little bit. So drawing past that, I was just wondering, based on your expertise, would a more serious impact that involved a true TBI have the ability to affect breathing difficulties and sleep disorders that could keep a patient from enjoying the benefits of REM sleep over a long period of time, even after using a CPAP machine and other sleep meds and things of that nature?
Well, I think that the reason why we're not shying away from it, but this, I mean, we could talk for a long time on traumatic brain injury, but concussions are now qualified as a mild traumatic brain injury. So it is thought to be a true traumatic brain injury. There are various traumatic brain injuries that can happen in addition to concussions, as you alluded to. And I think that if a concussion is a mild traumatic brain injury with those symptoms that can follow them, anything that is more severe in terms of intracerebral contusion, subdural hematoma, traumatic subarachnoid hemorrhage, can also have those symptomatologies that can last for a long time. Even mild traumatic brain injuries can have a long-lasting effect, not just concussions, but ones that are associated with intracerebral hemorrhage of some sort. They can have effects that can last over a year. And so yes, sleep disorder, attention disorders, mood disorders, lability, these are all things that we see. And it is a struggle for that patient population as well.
And our hope tonight is to have whet your appetite enough to go and look at the links that we've given you to find out more, because we could have a discussion tonight, we could have a discussion another night for at least an hour just on sleep and concussions, right? We could have a discussion on the neck and how the neck plays a role in recovery from a concussion. So there is so much more out there, to your point, that we just are hitting just the very, very tip of an iceberg to whet your appetite enough to please continue to educate yourself and continue to ask questions of your providers.
Dr. Ryan had 93 more slides that we were going to go through.
All right, to just wrap it up quickly, again, the point of tonight was a return to learn. And we have an excellent panel here. We have a strong cooperative team. We count on you, students and parents, to report and communicate and give feedback. So we thank you, and please thank our panelists and the whole Greenwich High School team for taking care of this.